Hello everyone, I'm Jamie Doucette. I'd like to welcome you to today's webinar on how interpreting claims analyses can help you improve care for your employees and their dependents and lower costs for you. Now we know that's not the most exciting title of a webinar, but as most of you are self-insured employers or benefits consultants, this topic is extremely relevant. Not only is there a potential direct impact to the bottom line, soft dollar areas like productivity, presenteeism, absenteeism, and others may also be affected. So before we get started, I'd just like to introduce myself for those of you who don't know me. I'm a leader here at Paladina Health and previously was the CEO of Modern Med, a company that recently joined forces with Paladina Health to provide employer-sponsored medical home programs. Also on the line is Eric Olmsted. Eric has a PhD in economics, specializing in healthcare, and works with these claims analyses every day. And I know what everybody is thinking, including myself, and he is such a lucky guy. He's here to help us interpret the case studies we'll be looking at today and help identify specific areas of opportunity and action. On an administrative note, we will be taking questions throughout the webinar, and we'll save time at the end to answer them. If you'd like to ask a question at any time during the webinar, please enter it into the Q&A tab and click send. Now let's get right to it. We're here to talk about is an in-depth claims analysis can benefit a self-insured employer and their broker consultant partners, and how, when used to guide healthcare benefits decisions, the information revealed in a claims analysis can directly impact the bottom line and quality of care your employees and their dependents receive. So why are we here? Why do we even care about our claims data can tell us about healthcare spending? Well, because regardless of what the specific number is, healthcare costs are increasing for both employers and employees at a faster rate than inflation. This is problematic for all parties because every year a greater percentage of each dollar is spent on healthcare costs and not spent on sales, research, operations, wage increases, groceries, soccer, other places businesses and their employees value much more than the benefits. There are many studies out there from Aon, Mercer, and others illustrating the trend in employer healthcare costs. Both Aon at 3.3% and Mercer at 2.1% showed some of the lowest cost increases for employers in 2013. With the economic recovery gaining momentum, however, both Aon and Mercer are projecting larger cost increases this year at 6 to 7% and 5.2% respectively. So while there may have been a dip in 2012 and 2013, the overall trend for the past decade, and certainly for the foreseeable future, is a relative increase in healthcare costs for employers. And the worst thing people can do is be complacent. Taking it one level deeper, as we look at the difference between employer and employee contributions, it's readily apparent that employee costs have increased at a faster rate than employer costs. And this gap appears to be widening over time, certainly indicative of something that I hear quite frequently when I'm out there chatting. Many employers have been playing the shell game of shifting costs for some time, but these same employers and their advisors believe that this is an untenable solution for the long term. In addition, the question a lot of us may be asking ourselves as our healthcare costs go up every year is, what am I getting for this increase? Am I getting additional services, better care, easier access? In all likelihood, the answer is unequivocally no. So let's take a quick poll of the audience here. Real briefly, how many of you know your average annual healthcare cost increases for the last 3 years? And I'll give you a couple minutes to respond before we move on. Got it. Looks like the increases we're experiencing are actually all across the board. The amount cost increase is dependent on a variety of drivers, and we'll be taking a look at those specific drivers next. And for those of you who aren't sure how much your costs have increased, looking into the cost drivers is going to be especially useful. Thinking about your overall cost increases is important because many of us currently measure healthcare spending success simply based on how closely our cost increases are to the national, regional, or sometimes industry average. For me, quite honestly, this is a typical garbage in, garbage out scenario. If the initial premise is garbage, and in this case the initial premise is that the average rate of increase should be the measuring stick for success, then the result will be garbage as well. This reality of being close to average performance isn't how we manage other aspects of our business, and certainly isn't a viable long-term way to manage what, for many of us, is our second largest G&A expense. For the long term, we need to understand where our money is going and make smart decisions about how and where to spend those very, very precious budget dollars. While many of us simply feel at the mercy of healthcare costs and their drivers in a pure price taker scenario, I've certainly been there, I wanted to show you this slide because I would argue that this isn't the case at all. It took me a while to get there, but I truly believe that. At the same time, these drivers won't go away on their own. Regardless of what's driving your costs, there are solutions and opportunities available. Eric, can you shed a little light on what's driving healthcare costs and how controllable those costs are?
I'd be happy to, Jamie. I also wanted to note that it's very important to understand these cost drivers. As you can see from the poll that we just took, 20% of you recorded an over 8% rise in PMPMs. And I think given what Aon and Mercer were showing in the more 2 to 3% range of increases, you can see that there's a wide amount of variation. So it's really important to analyze your claims and understand these cost drivers. As you can see from this slide, cost drivers including consolidation of providers, the aging workforce, and the fee-for-service healthcare structure are drivers that most employers don't have a lot of control over. In the traditional healthcare payment system, at-risk payers really don't have control over these drivers. You have some control over some other factors like cost disparity and lack of transparency through transparency tools or referral management programs. The highest level of direct control employers have is in their specific benefits design structure. But even these choices have limited impact on costs when implemented in the legacy healthcare system. Now, when you consider adopting one or more of the innovative approaches in the marketplace today, you can gain more control over many of these factors. So how does this relate to the claims analysis? Well, the analysis isn't just information for the sake of information. It's information that's designed specifically to help you in your decision making. And a deep dive into the spending and utilization patterns of your population can help identify precisely what tools and solutions are best for you.
Thanks, Eric. So while you're thinking about these cost drivers and looking at the case studies we're about to review, I'd like to invite each of you to set aside measuring your success against the percent increase of everybody else. I'd like you to consider that you could stay flat in your healthcare costs. Or, take it even further, what if you could actually lower your healthcare costs? And what if you could lower your healthcare costs and provide better care at the same time? These questions are the reasons that Paladina Health exists. We're here because the traditional model of care isn't working for employers or patients, really isn't working for anybody. That the status quo of year-over-year healthcare cost increases doesn't have to be everyone's reality. Many of you are familiar with Paladina Health, but for those of you who aren't, just a quick introduction or refresher. We're an employer-sponsored medical home in which our physicians serve the employees and dependents of a client's population through both on-site and near-site clinics, as well as 24/7 cell phone access to your personal physician. We've completely realigned incentives so that our physicians are held accountable for delivering great care and great service. Through our program, employers add a new physician option plan for members without necessarily having to make benefit plan changes. While this model delivers higher quality care, it also drives down healthcare costs in 3 powerful ways, which you can see on the chart. Redirecting care into a lower cost primary care setting, managing patient referrals to ensure high quality and value, and managing chronic disease and long-term conditions. What employers say varies based on several factors, including access to care, demographics, disease prevalence, and certainly incentive structure. Earlier we said you can't be expected to evaluate options without understanding your numbers. So let's dive into the meat of the presentation here. For the duration of the webinar, Eric mentioned it earlier, but we're going to move away from trend data and utilize per member per month, or PMPM numbers, in an effort to be more precise and control for factors like population size. By knowing and understanding the PMPM and the cost buckets behind the total number, opportunities for savings jump out pretty quickly. I'm going to turn it back over to Eric to provide some context into what you're looking at.
Thanks, Jamie. So what you're looking at here is an average PMPM and a breakdown of that spending based on a study from the IMS Institute of Healthcare Informatics. They looked at billions of medical and pharmacy claims data from privately insured individuals. And what this shows is that claims associated with chronic conditions are driving a significant portion of the total PMPM for the average employer. If this were one employer's analysis, I would definitely suggest taking an aggressive approach to chronic disease management to help lower that PMPM. One reason that we look very closely at PMPM when evaluating claims is because it can vary widely across employers. We've seen PMPMs as high as $500 and as low as $225. And oftentimes, these employers don't understand what their PMPM should be telling them, or they don't have a handle on what their PMPM is at all. And while PMPMs can vary widely, the case studies we're about to show are relatively similar, even though each employer has distinct and separate opportunities for savings.
Before we dig into the case studies, we're going to quickly take your temperature on PMPM. On the screen, you should see a question. Give you all a few moments to answer, and we'll share the results a little bit later. Great. Today we're going to look at 3 employer claims and analyses. This is real data, but has been de-identified, and the outliers have been removed. We do this for a few reasons. First, we can't plan for catastrophic illness despite our best intentions. The biggest expenditures that are preventable or avoidable are chronic conditions. Second, many of these costs enter into stop-loss territory. And third, the outliers are easily identifiable in employed population, and that's not what these analyses are about. They're about looking at the broader population and identifying real opportunities for longer-term savings. As you can see on the slide, the PMPMs for these employers are pretty similar. Eric is going to review some of the things we look for, and then we'll show you where those red flags surface in the claims.
Thanks, Jamie. The first thing that we do is try to understand the makeup of an insured population to identify the health issues that are present in your risk pool and the story that demographics and prevalence tell for the future. For example, is the number of diabetics in the risk pool low, medium, or high? Or how well are your high prevalence chronic populations being managed? Next, we're looking at how a person accesses the healthcare system. Are they not seeing a primary care physician but showing up directly in the ER? Are they seeing specialists without first seeing their PCP? Effective primary care offers tremendous opportunities for savings simply by addressing the way people are accessing the system. And lastly, we'll take a look at benefits design. While we know that it's important for employers to have an easy-to-explain benefits plan, for some populations a one-size-fits-all insurance plan doesn't work. An example of this is the case of a diabetic plan member. Many plans only cover one visit to the PCP per year. Diabetics are, however, recommended to have at least 2 visits per year. So this one-size plan is actually discouraging the appropriate use of care. And we're seeing many employers start to experiment with value-based benefit design. However, benefits design cannot solve everything. A prime example of this is what we call the low or zero utilizer, the time bomb, if you will. The member who shows up at the ER but never sees their PCP. No matter how high the ER copayment is, these people are going to go directly to the ER. Frequently, this is because they don't know what else to do. They don't have any other way of accessing the healthcare system. So the opportunity here is directing this care to a primary care setting so that these members understand how to access the healthcare system more productively. The best way to do this is to incentivize the primary care physician to have a direct relationship with your members.
In these cases, I tend to point out the incentives at play. Many of you know me, I'm an incentive junkie. Let's take an employee at home over the weekend who develops stomach pains. I'm sure we've all been there. If the employee doesn't have a doctor he or she can call, the only options are to wait it out or to go to the ER. This employee goes to the ER where the hospital is incented to fill all of their beds. Filling the beds pays their bills, keeps the lights on, pays their employees, pays health care benefits. So if they have empty beds, their incentive is to admit your employee when the outpatient medical management of the stomach pain might have been a perfectly reasonable option. Our incentive as employers, on the other hand, is to keep our employees out of the hospital for many reasons, not the least of which is the high cost. Also, in each of these cases, quality of care and service is not better. In fact, it's actually been shown to be worse when employees access care in this manner. Let's go back to the 3 case studies we talked about before. Employer A is a private company with a low number of dependents. Employers B and C are public companies with high numbers of dependents. All 3 companies' PMPMs are within about $30 of each other. But as Eric will show you, there are some key differences among their claims data.
So let's start with employer A. This employer's insured population is primarily employees rather than dependents. So the overall risk pool for this employer is a little older, no children, fewer children and adolescents in the pool. This shows up in the amount of healthcare spending allocated to chronic disease. This is a major cost driver for this employer. Aggressively managing chronic disease in this group is critical to lowering the overall PMPM. Another area that is driving expenditures is outpatient services. For this employer, outpatient physical exams and surgical procedures were making up a significant portion of the total spending. And these are areas where redirecting care to the primary care environment could help the employer realize savings. Employer B has an opportunity to redirect care back to the primary care environment as well. Outpatient and inpatient surgeries are a major cost driver for this employer. Outpatient physical exams are making up a very large chunk of the overall spending. And where we see an opportunity for primary care is that patients with a relationship with a primary care provider have someone who is working on their overall health and well-being. The idea being to keep them out of those expensive inpatient facilities. This often prevents the need for surgical procedures altogether. It can also help the patient find lower cost options. This is done through referral management, alternative treatments. In many cases, medical management is the preferred alternative for a member, and the member doesn't even know that that is an alternative, thinking that surgery is the only option. So in this case, employer B's employees are just going straight to expensive inpatient and outpatient procedures rather than being treated preventively, or working with someone to identify the healthiest and most productive treatment and healthcare system use. So we can see, again, underutilization of primary care providers is resulting in additional costs. And what we're seeing with employer C is an issue of referral management. The greatest expense we're seeing with these members is outpatient direct-to-specialist healthcare system access. When a patient goes straight to the specialist, you don't have any way of knowing if that's an efficiently priced specialist. You should really examine the pricing and know the pricing in your area of specialists so that you can effectively refer patients to high-quality, high-efficiency specialists. In addition, many services provided by a specialist can be provided just as efficiently and more effectively by primary care physicians. Your employees don't have any way of knowing whether they actually need to see the specialist, and the primary care physician will know. So you can see here what this means in terms of lowering the PMPM for these employers. Identifying the opportunities and targeting them through a variety of programs translates into big savings for these employers. It's important to note that in the fee-for-service structure, there is some low-hanging fruit that is evident in claims analysis for each employer. We have just introduced some of the areas where savings can be targeted. We usually can do a deeper dive into these claims and identify additional targetable opportunities. So before we move on, let's take a look at where your PMPMs are, and I'll give a little insight into your PMPMs from the poll we took a few minutes ago. Interesting. I think the thing that jumps out from this poll for me is that 40% don't know what the PMPM is. I think that that is something that would definitely be worthwhile to address, and understanding what your PMPM is and what is driving that PMPM can be very important. And I think this is a very important step to help you get control over your healthcare costs. You can also see, for those of you that do know, there's a pretty wide variety of PMPMs, $200 to $400, which is about what we see in the results that we get. So you can imagine how different the cost drivers and opportunities for savings are for this group. So with that, Jamie, I'll turn it back to you.
Cool. Thanks, Eric. So what's next? What do you do with what you've seen in the case studies and your own data? Well, here's a summary of the opportunities we identified in these 3 case studies and what we would recommend to address these issues. Once you understand your specific opportunities, next step is exploring recommendations. Each of you can do the math and see that on the previous slide we're identifying on average 30% PMPM savings. And if everyone could save 30% of their healthcare budget, I think everyone would do just that. To save that money, there is a certain amount of investment or spending that's required. Investment does have a return, and that's where you're bending or breaking the spending curve. In each of these case studies, we recommend investments in a combination of areas to 1, increase access and engagement of the primary care physician, 2, engage patients with primary care physicians who are accountable for outcomes and are acting as quarterbacks, there's my sports analogy for the webinar, for their patients' care, and 3, provide transparency tools. Each of these is part of a population health management, a healthcare model that's gained attention for its outcomes and efficiency. At this point, I'd be completely remiss if I didn't say that this model, population health management, is at the center of what Paladina Health does. Our model is designed to increase access and engagement between patients and their doctors. In addition, Paladina Health doctors are accountable for their patients' health outcomes, and we believe that this is critical to the success of any healthcare model. Now I want to show you how this all can play out for an employer. The employer we're profiling here implemented population health management through an employer-sponsored medical home. This employer had been seeing 7 to 8% annual cost increases, and as a note, we commonly see employer healthcare costs increasing 7, 8%, double digits year over year, not atypical. For this employer, a wellness program was in place, but had a difficult time determining whether or not they were achieving an ROI. The employer had taken steps to implement a consumer-driven health plan, so a high deductible plan. This employer is eerily similar to some of the case studies we looked at earlier. The employer has been seeing health declining in its population, high incidence of chronic disease and obesity. We examined the claims data with this employer and to address their particular needs made some specific recommendations, many of which were similar to the opportunities we identified with the 3 case studies that we looked at earlier. 9 months after implementing the population health management model, gross healthcare costs decreased by 25% for participants in the program. Interestingly enough, the individuals who chose to enroll were generally older and less healthy, with a higher incidence of chronic disease. And this is where population health management excels. Our last webinar was actually dedicated entirely to how employers like you can control chronic disease, and I recommend giving it a listen. Here's my little plug. The webinar is on our website at paladinahealth.com/chronic disease. Results for this employer were significant for employees with chronic disease, both in cost and in care. Patient polls showed that the patients with chronic disease were extremely satisfied with the service provided. And the patients with chronic diseases were more likely to access the services than those without chronic diseases. Now, Eric's going to walk us through the cost changes after just 9 months of population health management.
Thanks, Jamie. So while each of the case studies we looked at earlier had unique saving opportunities, you may recall that all 3 had high claims in specialty care, outpatient care, and inpatient facility care. And this is fairly standard. We generally don't see huge dollar opportunities for savings in either pharmacy or primary care. This case study, we saw very large spending in the outpatient services bucket. And so we wanted to understand what was driving that. In this case, the employer had very high chronic disease prevalence. So we know that chronic diseases are often the highest contributors to healthcare claims, and we know that these chronic members were spending a lot of money at outpatient facilities. So managing that chronic disease was one of the key identified opportunities and became a centerpiece of the population health management approach. The chronic population was also making excessive use of specialist care without a concurrent reduction in outpatient or inpatient facility utilization, which is what we would expect from high-quality specialist care. So redirecting some of this care to the lower-cost primary care setting, Paladina Health was able to cut spending by more than 1/3 in just these 9 months. So many of you may be wondering how that can happen. How does redirecting this type of care to the primary care setting cut costs for actual individuals with chronic disease? So let's take an example of a diabetic patient. Today, roughly 8% of U.S. adults are diabetic and another 35% are pre-diabetic. So this example likely applies to many of your employees. In the fee-for-service world, a diabetic often has several specialists, possibly spread across town, and frequently another primary care physician as well, none of whom are talking to each other. Depending on that diabetic situation and the quality of health, claims may be incurred in specialist, outpatient, and unfortunately inpatient charges. And often this results in repeated lab and diagnostic services. So if a diabetic visits his or her endocrinologist for a checkup, that is usually billed to you somewhere around $450. If that care is redirected to the primary care setting, the charges will be significantly lower, probably around $100 to $125 depending on your region. And in a subscription-based medical home, there'll be no charges at all. So across your insured population, redirecting care to the primary care setting will significantly reduce spending on these high-cost procedures without sacrificing quality. And, as Jamie mentioned, employees with chronic disease were much more likely to engage in their care and were highly satisfied. Getting member engagement in their own care is critical to total population health management. And this population of employees recognize the value of this benefit and thereby engaged in the program. So, the title of this webinar is Understanding Claims Data to Lower Costs and Improve Care. I'd also like to share with you some examples from this case study of how the employer-sponsored medical home improved care for actual patients. So what we're looking at here is patient A, who had been diagnosed with high blood pressure and diabetes. This patient specialists were not near their place of work, and that made regular visits to the doctor very inconvenient, so they didn't happen. The Paladina Health employee-sponsored medical home model allowed collaboration between the patient and primary care physician on an individualized care plan. This increased access to the physician allowed for real-time management of both diseases. And this member was able to engage with that physician and control their diabetes and lower their blood pressure within 9 months. So previously we gave an example of unnecessary ER visits for patients without after-hours access to their physicians. And this patient B is an example of an ER visit avoided. When a patient has access to his or her physician after hours, he or she will call the physician, discuss their injury or condition, and in many cases the patient can avoid a trip to the ER. Now that's going to redound to your bottom line, but it's also going to redound back to your members. We're going to be much happier to stay out of the emergency room. Patient C is another example of quality chronic disease management, but this example is different in one important way. The high cost of health care to the employee was actually disincentivizing appropriate care and resulting in underutilization. By providing better access and lower cost care to the employer was able to incentivize accessing preventive care and then thereby lower the risk of more serious illness moving forward. And I think that this example is incredibly important. This demonstrates the power analyzing your claims data can have on identifying opportunities for your low utilizers. Understanding your diabetic population, knowing who's using the healthcare system appropriately, who's using it inappropriately, and in the case of a diabetic, who's not using it at all, can provide a lot of opportunities for savings. And so while this employee exhibited a very low expenditure in the baseline year, we were able to identify them as a diabetic and provide an incentive for them to use appropriate care. And these solutions can have a strong impact on the odds of high future utilization. Pent-up demand for care and worsening conditions will often result in significant future claims.
Thanks, Eric. So before we wrap up, let's recap what we talked about today. And what I hope you walk away with is that employers, with a certain degree of control, we can bend or break this spending curve. We don't have to follow the benchmark of every other employer out there, and we can give our employees access to the health care they want and deserve at the same time. On the screen right now are 3 key steps for doing just that. I've already expressed interest in number 1 just by being here. For steps 2 and 3, you'll benefit from working side by side with your broker or consultant. Take a deep dive into the claims data to identify opportunities and improvement for savings. Then, and here's the exciting part, at least for us, start making changes. Depending on what you learn from your claims analysis, you may want to introduce a transparency tool like Castlight or Healthcare Blue Book. Other approaches you can take based on your results are exploring wellness programs or disease management services. On-site clinics are also options if the employee population is driving the majority of the cost or are the only ones eligible for those benefits. Here comes a bias alert. We are obviously biased. We feel the challenge that transparency, wellness, disease management services have, that they only affect a small part of the overall problem. And the challenge that traditional on-site clinics have is that they only serve employees, which is typically less than 50% of the healthcare costs. Usually nurses, mid-levels, so some care restrictions, often different reimbursement structure with misaligned incentives. And the other option you have, obviously, is choosing medical home population health management route, which we provide here at Paladina Health. Taking an approach that incorporates population health management truly flips healthcare service on its head. And as you've seen today, the results can be significant both in patient health and in cost savings. So whatever the approach you and your benefits consultant arrive at, making changes based on your health claims data, being open to innovative approaches can result in lower costs and employers getting better, more appropriate care. Don't hesitate to reach out to your Paladina Health contact if you have any questions about what we've covered here today. Many of us on the development team are looking at these claims analyses any day, and again, you're thinking how lucky we are, and can certainly help you understand the process. We've saved a few minutes here for questions. Again, as a reminder, you can type your questions into the Q&A tab and then click send to ask a question. I did have a couple questions actually that came in a little bit earlier. Question 1, what is the time frame for these projected savings? Eric, can you take that question?
Sure, that's a great question. So these savings are, for the 3 case studies that we looked at here, are projected year 1 savings. And generally that kind of savings includes the low-hanging fruit, the so-called quick hits you get from redirecting care to a primary care physician. In addition to that savings, truly effective primary care is going to generate savings over time. It's going to generate more and more savings in years 2, 3, and beyond. So you're going to see additional cost savings associated with your population getting healthier.
Great, thanks Eric. I actually have another question here. How do you know that you can redirect services to the primary care setting without cutting, or to cut costs? Eric, can you take that one as well?
Okay. So we actually get pretty granular in our claims analysis, and we've actually seen physicians moving utilization for specific services back to the primary care setting. So we tend to look at minor procedures, look for evidence of minor procedures that were being performed at a high rate in the specialty setting, and now look at the rate of those procedures being performed in a primary care setting. Additionally, we'll look at chronic members. How are they utilizing the healthcare system? And so if you look at it claim by claim, you'll notice that more chronic members are seeing their primary care physician at the appropriate rate, twice a year or once a year, depending on the condition. And we'll see a lower rate of emergency room utilization and inpatient events. So,
Great. Oh.
Yeah, I think that's it.
All right. No problem. Thanks. Thank you very much. Let me scroll up. Got time for a couple more. What is the difference between the Paladina model and a primary care physician practice certified as a patient-centered medical home? I'll take this one. I can think of kind of two basic differences. One is certainly in reimbursement. Our physicians are specifically incented to drive high-quality care, high-quality service in a primary care practice certified as a patient-centered medical home. There is still a significant element of fee-for-service reimbursement where there's a volume incentive at play, which we think is kind of the wrong approach specifically to primary care. The second is our team-based approach to care is a much smaller team. Our approach is that kind of the physician remains the center of that patient-physician relationship, remains the quarterback of the patient's entire healthcare experience. I think traditional or certified patient-centered medical homes have expanded that team approach to include coaches, dietitians, nutritionists, and so they've got a much larger team approaching a much larger panel. And we feel that a certain degree of the patient-physician relationship is diluted in situations like that. But certainly there are many similarities between a patient-centered medical home and the Paladina employer-sponsored medical home model. Thanks for that question. Scrolling through. Here's a good question. Is Paladina a PPO network, a care management organization, or a hybrid? I'll field that one as well. Paladina right now acts more like an IPA or an independent practice association with a network of physicians. Our physicians typically are credentialed in the networks and in the plans, but are not necessarily part of a broader HMO organization that I think the question was directed towards. Let's see if we can find. Thanks for the question. Next question. I assume Paladina has a network of physicians. How can a person access that network? You can access the network in two ways. One is certainly be employed by one of our clients. Our clients offer our program as a benefit, so it's free to employees and dependents to join our practices and receive care from our physicians. The second way someone can access our network is to find out where kind of the closest physician or closest clinic to their location would be, and sign up as a private patient. In a private patient scenario, the patient would be paying our per member per month fees, as there would not be a client relationship or an employer relationship in that situation. Great question. Here's a follow-up question. If you're an IPA, does that mean that my client would have to drop their PPO network to utilize their services? And short answer is no. Our physicians become credentialed in the PPO network to provide services to those employees and dependents as an in-network physician. Hope that clears that up. Got another question. I think a question quite a few people typically ask is if we're improving care, patients are getting so much time with their physicians, how are we making money? Certainly happy to discuss the specifics with anybody offline. Again, our model essentially plugs into existing benefits programs for self-funded employers. Employers do still have an insurance plan, called a wraparound plan in certain circumstances, where claims are still filed, certainly for the secondary and tertiary care claims. We are a subscription model, and so we earn our living on a per member per month basis, just as we talked about on the claims side. And the way we earn an ROI is by eliminating more claims than what we get paid, which we think is incredibly transparent and very cost effective for our clients. All right, let's see if we can find one more question. Any other questions? Oh, here we go. Two quick questions. Do you have locations throughout the U.S.? Short answer is yes. We are coast to coast at this point. I think at last count in about 13, 15 states, something like that. And but certainly for specific opportunities, we'll open up new clinics. Typically, we're looking at around a minimum of 500, we call them belly buttons, so 500 members enrolled in one of our practices to set up a new clinic, and certainly we're happy to set those up in an opportunistic manner. So willing to expand, willing to grow where those patients might be. The second, do you offer a savings guarantee? We do for certain clients that reach minimum thresholds of enrollment. Typically right now, our minimum threshold for the savings guarantee is 1,000 enrolled members on average. So hope that answers that question. And I think we are just about out of time. So that's all the time we have today. I'd like to thank each of you for joining in on the webinar. Certainly thank my co-presenter, Eric Olmsted, for his time today. I'd like to invite each of you to our next webinar, Real Patients, Real Stories, the Employer-Sponsored Medical Home Experience. The webinar is going to take place on Tuesday, April 22nd at noon Mountain, and is going to feature first-hand patient stories accompanied by one of our Paladina Health physicians sharing the patient perspective on the employer-sponsored medical home. You can register for that at paladinahealth.com/webinar. This webinar was recorded, and the replay will be available at paladinahealth.com/webinar replay later this week. I look forward to seeing you on future webinars, and thanks so much for your time. Have a wonderful day.